back with one more event today, and I'm glad to be here again with Dr. Elias Tsakos. You can see him right here. Hello, Dr. Tsakos.
Hi,
Welcome back.
everyone.
You've been here before many times, and I'm really looking forward to our event. It's always an interesting topic. We've done this topic before, that's the truth, but this is a topic that we definitely need to discuss more. And as you mentioned yourself, this is the topic that you enjoy the most, hysteroscopy. So I'm glad that we have such an expert here with us today. And of course, remember that we are here for you. So we will start with Dr. Tsakos' presentation on hysteroscopy and what can be done, what we need to look for, etc. And afterwards, there will be time for your questions. And as always, all you need to do is just type the questions in the chat, and Dr. Tsakos will definitely answer them for you. If you've been to our events before, you know that it's going to be an interesting session, I'm sure. So thank you so much for joining. And Dr. Tsakos, welcome back. How are you feeling? I know it's been busy. It's always busy for you. I know it. So how are you?
It's
Hope all is good.
wonderfully busy. So, we're very happy today. We had a lot of positive results and lots of positive outcomes. So we're excited, although it's 9 in the evening here in Greece, and we've been working
True.
till 7 in the morning. So thank you so much for the introduction. Thank you so much for hosting this event once again, Caroline. And thank you all of you who are, dedicating precious time to listen to us. So, I would like, obviously I can see some of your names. I recognize some of them, but if you can write down where you're listening from, it would be nice to understand where on the map of the world you're located. So let's start the presentation. I will keep it short and sweet as usual, so that we have time for questions afterwards. So let me start. So the presentation shouldn't take longer than 20 minutes, and then we should be able to have another 20 minutes for discussion. Is that okay, Caroline?
Definitely. Let's go for it. Let's start.
Brilliant. So hysteroscopy. It's a very specific topic, and that is hysteroscopy before IVF. It's not hysteroscopy overall. It's not hysteroscopy for fibroids or myomas, is it? It's not for bleeding, for vaginal bleeding. It's hysteroscopy before IVF. Can it improve outcome? I mean, that has been the question for many years, many decades. I was fortunate enough to come across hysteroscopy in the early 90s, so that's about 35 years ago. And I've always thought that it goes without saying that the gold standard of diagnosing the uterine cavity is the insertion of a telescope so that we can visualize the cavity. I mean, as you probably know, most of the human body's cavities can be visited. Hi, Ulm, hi, Germany. They can be visited through a telescope. So if we have a sore throat and we have a cough that doesn't go away, then we put a telescope to see what's going on. If we want to examine our nose, our ears, our gut, our urinary system, we put a telescope in. Laparoscopy. Laparoscopy became more popular a few decades before hysteroscopy became popular. And this didn't make sense to me because hysteroscopy is technically much more easy. It's much less invasive. It doesn't involve any cuts, any incisions, and usually doesn't really involve serious anesthesia. We can do it without anesthesia. And why is that? Because the orifice is there, through the vagina, through the cervix, through the neck of the womb, into the uterus, and voila, there we are. So I've always been curious when I came across this technique in the early 90s, in 91, to be honest. Why was it popular at the time? Why was it part of the standard management? It's not an operation. It's a procedure. It's a diagnosis. It's an endoscopical assessment. I haven't been able to answer this why yet. I'm working on it. Basically, I feel that it's probably because, especially in the context of IVF, we've become very good in IVF. We've become very good in creating, I mean, the labs are amazing these days. The results can be outstanding. And we are a little bit spoiled by our successes. So perhaps sometimes we don't look into perfecting them a little bit more, adding perhaps another 5 or 10%. To me, even 1% improvement of overall pregnancy success is important, because most of us, we perform, a few hundred cycles minimum a year, maybe 500 cycles. So 1% of 500 cycles would probably be 5 more pregnancies, which is 1 extra pregnancy every couple of months. And I'm here to prove to you that, to show you the evidence that perhaps the improvement is not as low as that 1%. In our own study, it showed that the improvement of outcome was 10% in egg donation cycles, and we presented that in the British Fertility Society conference in Edinburgh 5 years ago. So that is my overall position. I mean, I believe that hysteroscopy should be part of the pre-IVF workup, especially as we are now faced with women of advanced reproductive age, not biological age. I mean, the age of 40, 45, 50, in biological terms is still a young age, but in reproductive terms, it's probably a little bit advanced. And of course, the incidence, the chance, the possibility of those women having factors in the endometrium becomes increasingly possible. So I'm going to talk about the what's in the house. I'm going to talk about applications in fertility, assessment via hysteroscopy, treatments, enhancement of fertility through hysteroscopy, and of course the value of the novel approach of hysteroscopy, which is the hysteroscopic management of miscarriage. Hi, Parthena from Thessaloniki. Hi, Emily from DRC. Right, what's in house? So this is hysteroscopy. I mean, actually, this image is the first one I used for my leaflet when I came back to Greece in the late 90s. So it's a very simple instrument, fairly inexpensive. So what you need is a camera, you need a lens, and you need the light system here and the irrigation system for the water here. Please remember that the uterus is not a cavity, it's a potential cavity. So by irrigating with water, we create a cavity so that we can see better the pathology. So what do? We visualize directly the cavity by the use of a special instrument, infusion of saline. Usually, I mean, in the past we used to utilize other solutions, but we found that we had some issues with them, especially with operative hysteroscopy, and of course all the components of the hysteroscope. So some people use a speculum, some people don't. This is a fantastic instrument, which is the flexible, as you can see, flexible hysteroscope. We are privileged to have all those gadgets here in our unit. The advantage of this is basically you can use it without anesthesia, without even a speculum. And of course, you can control the bending of the instrument so that you can go straight into the uterine cavity. So through the vagina, through the cervix, into the cavity. Right. What are the types of hysteroscopy? Diagnostic hysteroscopy. Basically, this is when there's nothing visible in the fertility context. We perform a diagnostic hysteroscopy even if the scan is normal. And why is that? Because the scan is unable to diagnose fine details in the endometrium, which may include infections, endometritis, adhesions, like mild Asherman syndrome, or small polyps, or polyps located in a weird location, sometimes hyperplasia, and all of that. So we may even, we embark on a diagnostic hysteroscopy even when we expect that it may be normal. In my experience, we find that especially in women over the age of 35, even more so if they're over 40, the chance of diagnosing pathology that has been missed by ultrasound is probably as high as 30%, 1 in 3. Now, what is the importance of diagnosing this pathology? Depends on the pathology, depends on the age. But to my simple mind, if we are going to use the endometrium and the uterus for embryo transfer, and if we accept that this is the most important organ, to accept the embryo that we have worked so hard to create, and I mean both patients and us in the lab, in the theaters and all that, it would be a miss if we have some pathology that may create an issue in the future. And operative hysteroscopy is when we operate at the same time. Sometimes we know that beforehand. Sometimes we discover this during the procedure. So these are the main types of hysteroscopy. To my opinion, I believe that outpatient hysteroscopy, diagnostic hysteroscopy is very easily done and should be set up. And I understand that most IVF clinics, including ours, we have this set up. Of course, it's in an operating theater with the presence of an anesthetist, anesthesiologist. Although rarely we use anesthesia, we may use no anesthesia, local, or sedation. And of course, we should be equipped enough to be able to perform some sort of operative hysteroscopy, if not advanced sections, but definitely we should be able to remove a small polyp or divide a small septum or clear some adhesions. So the advantages are minimally invasive procedure, minimal, if any, complications or morbidity. I would quote less than 1 per thousand. There's no scars, no incisions, and it remains the golden standard of diagnosis of endometrial conditions. And of course, it can be performed in the context of one-stop clinic. I mean, in our practice for local patients, we offer one-stop fertility assessment, and this may include a diagnostic hysteroscopy with no anesthesia if there's no expected pathology. So what are the applications? Uterine cavity assessment. This is very important for every patient, especially of advanced reproductive age, but even more important in recurrent miscarriages and unexplained infertility. So what do we see? We see polyps, as you can see here. We can see myoma, or we can see a septum. And of course, sometimes we expect that, sometimes don't. With the advent of high-resolution 3D scanning, most times we know what we expect. And of course, we are prepared accordingly in terms of A, defining the setup, the setting, the clinic, the location where we're going to do the hysteroscopy at, and B, of course, to counsel the patient appropriately. So restoration of normal uterine anatomy via metroplasty. I mean, metroplasty is a Greek term for restructuring the uterus. Before the existence of hysteroscopy, that was performed by huge operations, creating huge collateral problems other than adhesions and infections and all that. These days, we can very easily correct congenital anomalies with diaphragms through hysteroscopic operations. Right, so what do we treat? Fibroids, congenital anomalies, polyps, adhesions. These are different types of hysteroscopes. We can use a loop, we can use the shaver, the morcellator, we can use the scissors, depending on what we find. Uterine fibroids, fairly common pathology. Around 50% of women in the Western world will develop fibroids during their lives, and that is about 80% of women of African origin that may have fibroids in their lives. So tumors that they grow within the uterus, outside the uterus, sometimes in the cavity. Some of them, especially the ones into the cavity, these are called submucous or submucosal fibroids. They are associated with negative outcomes. So it goes without saying that if there is some sort of pathology of this type, it is imperative that it is sorted out prior to IVF. Here we can see congenital anomaly, uterus didelphys. This is more uncommon compared to diaphragms, which can be solved and sorted out nearly 100% with the hysteroscopy, and sometimes with a combination of laparoscopy as well. Here we can see different types. It seems that these are the commonest high-risk types, and of course this type, the septate uterus, may be associated with miscarriages and premature labors. Here you can see the outcomes of managing the uterine anomalies, the congenital anomalies, by hysteroscopy, and as you can see, there's up to 50 times better outcomes compared to controls, compared to just watching that and going on with IVF. And of course, you can see a reduction of miscarriage rate by 98%. So there's huge evidence that this is helpful. And of course, most of these conditions can be diagnosed by scan, and then we go on to performing the hysteroscopy. And the same applies to preterm labor, which is associated with those conditions. Next application is improvement of fertility independent of other factors. Why? Because hysteroscopy may have a fertility enhancing effect, which may be due to the procedure itself, may be due to a little bit of dilating the cervix and ensuring that the cervical canal is not narrow, is not bent, is not full of adhesions, and that guarantees an easy embryo transfer. And of course, this familiarizes the doctor, especially if we're in the same team performing the hysteroscopy and the IVF, in order to map the road to a smooth embryo transfer. On top of this, the little bit of biopsy we take sometimes, or the scratching we perform on the endometrium, seems to be improving the implantation chance. Here we can see that, basically this is the answer to the question of my talk. Does pre-IVF hysteroscopy improve the fertility outcomes? And the evidence is that yes, it improves overall 44%. In our study, it was a little bit less than that. I believe that it's anywhere between 10 and 44, which is pretty significant. And of course, even more importantly, there's 30% improvement of live birth rate. So, in the context of IVF, all the pre-IVF testing, all the investigations we do, the drugs, the cost, the traveling, the stress, I think that the add-on of hysteroscopy is very minimal compared to the rest, with a very, very good contribution to the overall success rate. Now, a novel application of hysteroscopy, I believe that most of you may not have heard of it yet, is something, again, that to my mind sounds very logical. If we've stopped performing blind DNCs for polyps and fibroids and hyperplasia, why do we keep performing blind DNCs for miscarriages, for the management of miscarriage? And why don't we use the advantages and the benefits of hysteroscopy in the situation which is needed most, which is the miscarriage? And why is that? Because in a miscarriage, miscarriage is a very, very common form of pregnancy loss. About 1 in 4 pregnancies are lost through miscarriage, and the majority of them are happening in the first 12 weeks. And how do we manage that? There's medical management, there's surgical management. I'm not going to go into to when and why and so forth. All I'm going to say that a good proportion of miscarriages end up with surgical management, which is a blind procedure in most places, I would say. I would challenge anyone here, especially if there's any doctors listening in, any gynecologists, that I would say globally more than 90%, 95% even of evacuations of retained products of conceptions are done blindly. So I'm going to be a little bit provocative here. I believe this is not good. I believe that we should move on to using hysteroscopy in this context as well, in order to remove the retained products of conception. And what are the advantages? Theoretically, and of course, proven by evidence. Firstly, we go and remove the sac. I mean, sometimes the sac is here, sometimes it's there, and so forth. So we target the area of the abnormal gestational sac. Secondly, we have huge precision in just operating in this little area where the sac is located. By doing this, we achieve minimal injury to the surrounding area. And of course, the surrounding area, which is healthy endometrium, we need that for the future. And on top of this, together with the management of the retained products of conception, we killed two birds with one stone, because we do a diagnostic hysteroscopy, which is going to be valuable in the future. I mean, how many times some of you or all of you, if you've had a miscarriage, following either the medical management or the blind ERPC, evacuation of retained products of conception management, how many times have you not been suggested to have a hysteroscopy, like a couple of months later, to make sure that there was no associated factors that produced the miscarriage? So by doing hysteroscopic management of retained products, we killed two birds with one stone. And here's the evidence. There's very good evidence in my clinic. We've been using this technique for quite a few years now. I'm fully convinced. I mean, with a 35-year experience in hysteroscopy and with thousands of hysteroscopies, I'm now fully convinced that this is the way forward. To be honest, I have stopped performing blind evacuations of retained products of conception for miscarriages for many years now, and here's the evidence. You have complete resection rate, you have very low complication rate, and here is even small complications, 2%, a little bit of more ache or pain and a little bit more painkillers than normal. It's a very safe procedure. And then, of course, the outcomes, the clinical pregnancy rate is very near 90%, with increase of live birth rates and decrease of pregnancy loss. Here we see another study, very recent study. I mean, we are very, in our unit, in our clinic, we have a dedicated research and development department. And, there are dedicated, amazing fellows looking onto all the new evidence, all the literature in the areas that we are practicing. So recent meta-analysis showed that there's increase of pregnancy rate after hysteroscopic evacuation, faster time to conception, 5 times less complications, almost 0%, well, 0% having to go back for reoperation for retained products of conception. And of course, a reduction of significant bleeding, because if there is significant bleeding, then we can always cauterize and manage it through the hysteroscopy. So I'm just about finishing now. So take-home messages. 1, hysteroscopy is a very valuable diagnostic and therapeutic tool in assisted reproductive technologies. Very, very important. It's safe, incisionless, no incisions, minimal invasive. I would call it solution. I wouldn't call it procedure, I wouldn't call it surgery. It's a solution, okay? It can treat several conditions, and even if in the absence of abnormality shown on the scan, there is a good chance, 20 to 30%, which in the context of fertility is very important, that hysteroscopy may improve the fertility on its own. So my belief is that hysteroscopy enhances fertility and reduces miscarriage rates in most patients. This is the literature. For those of you who want to dive into more scientific evidence, feel free to copy that, take a screenshot. And I would like to thank you very much for your attention. I'm available for another 20 minutes to answer questions. If you want to contact us for a second opinion or a free video call, I'm more than happy. So, shoot an email to info@embryoclinic.eu, visit our website and follow us on the social media. I would be delighted. Please quote Fertility Answers, European Fertility Society, and I would be delighted to connect with you and possibly, give you a little bit of my experience in order to improve your fertility journey and fertility outcomes. Thank you very much.
Thank you so much indeed for your thorough explanation. And of course, right now we will go for the question. Let's not waste any more time and go for those. Dr. Tsakos, as you can see, plenty of the questions are here. And we have some guests from Slovenia as well, in Nigeria. Thank you so much for joining, for sure. Lots of people from all parts of the world. We are happy to see you here, for sure. Let's have a look. Okay, the first question is from Elisa. So, are there any risks or discomfort associated with hysteroscopy?
Sure. I mean, there's no procedure, there's no intervention without risks. I mean, even sitting here on my computer has a risk. It may blow up, or may get electrocuted, but the risk is extremely small. I mean, I would say serious risk is less than perhaps 1 in 10,000, and mild risk is less than one per thousand. So minimal risk. I mean, like everything in medicine, we try to balance risk and benefit. And regarding hysteroscopy, the benefits still outweigh significantly any potential risks. Now, with regards to discomfort, depends on whether it's just diagnostic, or I call it micro-operative. If it's a small pathology, then the discomfort is minimal. I mean, as we all know, discomfort is a very personal trait. So, some people react differently. But overall, women after diagnostic or mildly invasive hysteroscopy, they walk out of the clinic within a couple of hours maximum, and they go back to their normal activities on the same day. After an operative extensive, I mean, there are extensive operative hysteroscopies for huge fibroids or big, thick diaphragms or combined pathology. In that case, it may be a little bit more uncomfortable, but they don't require any more than just simple painkillers.
Mm-hmm. Okay, I think that answers your question. Thank you so much indeed for that. Okay, so hello from London. Is there a limit to how many hysteroscopies you can have? Can be done, right? You can have.
Well, a difficult question. I don't know is the answer. I'm trying to think how many have I performed on the same person, and it's probably 5 or 6. Depends on the indication is the answer. The commonest reason for repeat, well, put it this way, the most challenging pathology to treat hysteroscopically is adhesions or Asherman syndrome. All the other pathologies, they usually require 1 or 2 procedures. I mean, I would say 9 out of 10 of uterine pathologies can be treated with 1 procedure, and perhaps 10% they may require a repeat procedure in a month, 2 months, or 3 months. So if there's a huge polyp, or if there's a massive diaphragm, or if there's a fibroid, sometimes we remove them in 2 steps. The more experienced we are, the less this becomes norm. I mean, in my practice, I think probably happens once every couple of years that I have to go back very quickly for a repeat procedure for those indications: polyps, fibroids, diaphragms. Now, with adhesions, it's a different ballgame. I mean, in those conditions, polyps, fibroids, diaphragms, we can be confident that we can cure them 100%. We can confidently say to our patients, it's going to go away. Yeah. With adhesions, we do not have this confidence, because adhesions effectively is the replacement of normal uterine tissue by scar tissue. And as we all know, at least with superficial scars, there's no surgery without scars. And even if we try to remove a scar, there's still going to be a smaller scar replacing it and all that. So adhesions, endometrial adhesions, which may be caused by infection, surgery, or both combined together, is the most challenging pathology that we are called in to treat. In those cases, we may need to do 3, 4, 5 procedures. Okay. Now, if the hysteroscopy is done, and things are sorted and we're happy. It is valid, if you like, to my opinion, for about definitely for a year, maybe 2 year, a year and a half, 2 years, depending on the age. So if a young woman has a hysteroscopy at the age of 36 and there's no pathology found, I would feel confident not to repeat it for 2 years, because you see pathologies change. Someone may not have a polyp or adhesion or or infection, endometritis, at 36, but they may acquire at 38. So for standard patients, I quote that a normal hysteroscopy is valid for maybe a year, year and a half. Um, and then, of course, if I need to repeat it, it doesn't cause any harm. I mean, usually we don't dilate the cervix, we don't touch the, it's a little bit of a no-touch technique. So I wouldn't say there's a limit. I would hope that someone wouldn't need more than 2 or 3 before they have a full family.
Okay, makes sense again. And we actually kind of answered this already, because the question is, if hysteroscopy is done for adhesions, does it always improve uterine lining?
I never use I never use never and always. Okay, no is the answer. No, it doesn't always improve. I mean, when we suspect adhesions is the most challenging part. It's like trying to grow grass around the goalkeeper's post. It's always very difficult. So the first hysteroscopy I do, I mean, I think it's important to partner with your patients. I partner with my patients. We sit down, have a cup of tea, and just decide, just discuss, and say, okay, listen, I suspect adhesions. I don't know. It's very likely that we may find adhesions. Why? Because I see very thin lining. Because you had, a couple of DNCs. Because you had an infection in the past. Because you had a difficult birth with a placental abruption or whatever during birth. I mean, there's a lot of reasons why someone may have adhesions. Because you're having a very small amount of bleeding every time you have a period and all that. So I suspect adhesions. Adhesions, there are various types. They could be fine, they could be dense, they could be massive, they could be local. Let's do a diagnostic hysteroscopy to see what's going on. So my first hysteroscopy for adhesions is always diagnostic, to be honest. And then I sit down with the patient and I say, okay, fine, you have, Asherman's syndrome type 2. This is a little bit challenging. It's never going to be perfect, your uterus, and I will try to make it as near perfect as possible and improve it maybe 80% or 90% or enough in order to sustain a pregnancy. So no, we can't always. Sometimes we can't even start. I mean, I have done diagnostic hysteroscopies where there was no cavity. In those cases, I mean, the prognosis is not very good. We may perform 5 hysteroscopies and we may still have that there's no cavity. I mean, at the moment, I have 2 patients with severe Asherman's. One of them, it was severe Asherman's, but it was fairly localized. So we managed to navigate through some pockets of healthy endometrium. It took us about 6 to 8 months for the first embryo transfer. She had the first miscarriage. Unfortunately, we managed that with hysteroscopy. Actually, that's a good case to be published. To cut the long story short, then we did a hysteroscopic management. There were still adhesions, but mild adhesions. She got pregnant again, second time. Very difficult IVF with PGTA for various anomalies because of advanced age. Miscarried again, second miscarriage. Again, hysteroscopic management. We had one more embryo. We done a HSG on her because I was very concerned about very thin uterine wall where the section was performed, and there was a little bit of sometimes when the uterine wall is very thin, when you inject the dye, it goes through it. There was that phenomenon. However, it was very localized. We did the diagnostic hysteroscopy. To cut the long story short, the lady is 16 weeks pregnant now, normal uncomplicated pregnancy. Of course, my biggest fear is this myometrium going to withstand the pregnancy? So I'm planning to admit her to the hospital at about 32 weeks for observation in case we have any sort of worry about the integrity of the wall. Actually, we delivered a similar case with a very big and thick diaphragm, where she had a very fine fundus of the uterus and all that. So, it can be very tricky. I mean, to be honest, sometimes I ask one of my colleagues to have a look as well. I mean, I'm very lucky that in Greece, there's a few of my colleagues, very experienced. So one of them, I actually asked them to travel to Athens, 1,000 kilometers, 500 and back, just to get another opinion. They're challenging cases. And at the moment, I have another case, was actually a medical doctor with, very difficult uterus with multiple Ashama surgeries. We managed to get an endometrium lining of 6.7. And on her, we performed PRP, platelet-rich plasma on the endometrium. Again, this is something that has been around for over a decade. My team and I hadn't been convinced about the evidence. Some people are not convinced even now. Having said that, there are some very good meta-analysis, very good studies published in 2023 that indicate that for those patients, there may be a benefit. We performed PRP treatment on her. We haven't seen the result yet. We haven't dared to do an embryo transfer yet, and so forth. So, these are the weapons. The weapons are hysteroscopy, hysteroscopic surgery, and perhaps PRP if we want to, to really fight for that uterus. I mean, don't forget, and I will stop here, I have big passion about the uterus because most people believe that it's all in the embryo. Yeah, the embryo is important, but the uterus is also important. It's like trying to decide what's more important for a vineyard. Is it the soil, or is it the seed? I think it's both. So let's not forget that one in 5,000 women, it's a very small percentage. 1 in 5,000 women of reproductive age, they have what we call absolute factor infertility, absolute uterine factor infertility, which means that the endometrium is not treatable. And even for those ladies, in the fertility context, there are two solutions. One is very established, very standardized, which is surrogacy, and the other is uterine transplantation. Which again, my team and I have been very fortunate to be involved with the first people in the world, the pioneers, the Gutenberg group, Professor Branston and Dr. Milenkovic, and we're even looking into that because we know only too well, because sometimes there's nothing you can do for a damaged uterus apart from perhaps transplantation.
Okay. Thank you so much for your very thorough answer here. Definitely an interesting story and also answer for sure. Okay, so is hysteroscopy always suggested before, is it suggested before every transfer?
No, of course not. Of course not.
Yep.
I'm very, our team and most teams, we're very aware that there's a lot of ammunition, on the shelf, and we don't pick it out every single time. So, it depends. I mean, if we have a straightforward, young couple, 34, 35 years old, with unexplained infertility, normal scan, normal history, everything normal, no, we wouldn't do it.
Okay.
Now, for women over 40, I tend to do it, to be honest. I'm also very much aware, because I'm a gynecologist, because my pedigree is mainly surgery. I'm a surgeon who became an IVF specialist and not vice versa. And why is that? Because in the early 90s, we used to do retrievals through laparoscopy. So you had to be a surgeon. I mean, at those times, you had to be a fertility surgeon and then a fertility medicine expert. In our years now, after 2010, perhaps, in my opinion, you can be a wonderful IVF specialist without any training or any practicing of surgery, which is also fine. No, not for everyone. I was saying that I'm very conscious of the risk of malignancy in the endometrium. You know, endometrial cancer is commoner than we think. Commoner than we think. And why is that? Because it's also associated, and it's not just cancer, but even atypia. You know, atypia is like the precursor of cancer. And why is that? Because one of the risk factors for this condition is obesity, which is not uncommon for women in their 40s. Polycystic ovaries, which is not uncommon with women with infertility. So, and also, you know, somehow it seems to be more common. I mean, I don't know if it's proven, but we seem to, I mean, in our department, we see maybe, you know, in our fertility unit, we see 1 or 2 endometrial atypias or cancer a year. And those are invariably in women over 40. Some of them have associated pathologies, so we're lucky, if you like. So we see a polyp and we say, let's go. We remove the polyp and then comes back as cancerous polyp. Or we see thick endometrium hyperplasia and comes back as hyperplasia with atypia. So in my opinion, I think before you start, you know, let's not forget that over the age of 38, 40, you know, we need to ensure safety for our women. You know, we need to ensure that, you know, if they get pregnant or if they don't get pregnant, they have very good screening. And to me, breasts are very sensitive. They have to be screened properly. I'm very, very aware of the screening protocols in various countries, which are not brilliant. You know, some countries, they start screening at 45. You know, 1 in 7, 1 in 8 women will develop breast cancer, and 15% of them, 15% of those women will be less than 40 years old. So how will we justify, how are we going to sleep at night if we done IVF and somebody delivered and then when she was breastfeeding, she discovered that she had advanced breast cancer because she had never been screened. So in my department, no one, absolutely no one goes through IVF because IVF results in pregnancy overall, you know, with a chance of very near 50%. And the cumulative per effort and the cumulative chance of pregnancy with 2 efforts very near 75, 80%. So if this woman has an undiagnosed cancer somewhere, the chance is small. Is it 1%, 2%? That's 5 or 10 women in my clinic every year. And to be honest, the most gratitude I've ever had was not from women who achieved the impossible. Yes, I've had lots of that. But for women in which I insisted, and actually recently I had a wonderful woman from Serbia who I insisted on breast assessment. We discovered breast cancer. She went on to surgery, chemotherapy, and she keeps sending us thank yous every month, every single month. So because she understands only too well that we saved her life. Equally with hysteroscopy, we diagnose about 2 to 3 cases a year in women over 50 with atypia or cancer. I have performed you know, a total radical hysterectomy on a 42-year-old woman last year who came to have IVF, and she had endometrial cancer. And similarly, fibroids, you know, don't forget fibroids. They're not all benign. Yeah, most of them are benign. 1 in 500 are benign. Or sorry, 1 in 500 are malignant. So 2 per 1,000. But there's tens of thousands, hundreds of thousands of women with fibroids, you know, wandering around. So I'm very conscious of that. I'm sorry, my passion, but I, you know, I'm happy that, you know, I've been strict enough and to insist on breast assessment and hysteroscopies. And until now, I've been really blessed not to have had an undiagnosed cancer on a woman, you know, a year after I've done IVF.
Thank you so much. Very important stuff here for sure. So thank you so much. We will be slowly finishing. There are a few questions left. 2 of them are actually very similar. So if hysteroscopy is done, when should IVF be done? Is it possible to do it in the same cycle?
Sure, of course. Depends is the answer. Depends on how, why we do it. If, to my mind, there's three indications for PRP. One is unexplained implantation failure. We have beautiful embryos, good quality embryos. We've done 1, 2 transfers, 3 transfers. Endometrium looks fine. Nice shape, nice Dopplers, nice trilaminar, no success. In that case, the theory is that there may be something functional, which may be improved by PRP. So that's that. In that scenario, where everything looks fine by scan or even by hysteroscopy, I would do it for 4 to 5 days before embryo transfer. So just one PRP injection through a uterine catheter, like an embryo transfer catheter, 4 to 5 days prior to the embryo transfer. Now, can I make a little note here? It took me 5 to 6 years of investigation before I pressed the button to perform PRP. There's a lot of areas we don't know, and there's a lot of unknowns. One of the biggest unknown is we don't really know exactly. Most people who did PRP, because I interrogated dozens of my colleagues, and I was surprised to find that most of them, they didn't know what they injected. You do all the centrifusions, you do all the preparation. Okay, you squirt it into the uterus. What have you given? Do you know? So in my practice, we always do quality control. So we aim at achieving 1 million concentration of platelets. Just mark this down: 1 million per microliter. And of course, we do quality control on every single specimen for every single patient, because the ability to produce this specimen depends mainly on the concentration of the platelets in that person's blood, and also on the amount of blood that we have worked on. During my interview with my colleagues, I was also very surprised to see that some of them are using 5 mL of blood, concentrating down to 1 mL, and some of them were using 30 mL. So what is the optimum volume of blood we need to draw? So now we know that it's 2020. It took us about 2 years of working with my wonderful people in the lab in order to standardize the procedure so that we ensure that we give the right concentration. We need 1 million. Most PRP applications in other specialties, like the face or vaginal rejuvenation, or even cartilage orthopedics, 300,000 to 400,000 is enough. So most of the labs that prepare that for those uses, they're not used. They don't have the right equipment. They don't have the right tubes, the right bottles, the right position of the tube, whether it's perpendicular or horizontal and all that. So there's a lot of tricks of the trade there. So anyway, that's indication number one. So unexplained failure, 2 to 3 times, implantation failure or miscarriage, I would do one single PRP injection 4 to 5 days prior to the embryo transfer. Now, second group are the group with okay endometrium, but not brilliant. So, endometrium on the thin side, 7.5, 8.5, 8.2, not so good trilaminar appearance, not so good Dopplers, the thick line not so thick, perhaps a little bit of irregularity on the surface on the scan, or visible defects on the hysteroscopy. Now, for those patients, depending on where they live, if they live locally, I would probably do one injection perhaps, a month before, and then perhaps another injection during the treatment cycle. If they don't live locally, I would probably perform one injection in the beginning of the stimulation, maybe day 7, or if it's a frozen embryo transfer, a little bit later, day 10, and then the second injection a little bit before the embryo transfer. And then there's the third category, which is like the ladies I described with terrible endometrium, less than 6 millimeters, many adhesions, multiple hysteroscopies, Asherman syndrome, one spot of period every month, indicating very, very small amount of healthy endometrium. In those, we just don't know. I would do one every month perhaps, and I would assess. There is a score of the endometrium every time to see when is the optimum time and all that. So we don't know. In those ladies, I would probably do many more before the actual treatment cycle.
Okay, brilliant. Thank you so much. Let me go straight to the next question. It's a follow-up. Okay, so sorry, did you just say that PRP should be done days before embryo transfer? So when is PRP in ovaries advised to do, as in how long between PRP and, for example, egg collection egg collection? Sorry.
PRP for the PRP for ovaries, the endometrium PRP, there's enough evidence. I mean, of course, depends on how harsh you are. I mean, recently there's a study by Cochrane, and they were quite harsh on on assessing. It's very difficult to set up a good study. I mean, that's for sure, and especially in fertility where there's so many factors involved. It's very difficult to match the patients. Very difficult to find controls. What about the embryos? They all have to be PGTA tested if you are to match them. So it's very difficult. So a lot of it has to be empirical. I mean, there's no other way, and we accept that. Having said that, for endometrial PRP, to my mind, there's enough evidence to apply it clinically. Enough evidence in the literature, especially in the two big meta-analyses that came out last year. For the ovarian PRP, the evidence is just now being accumulated. So it is not as strong as it is for the endometrium. We're hoping, my team and I were just gathering all the data from our practice, and we're hoping to understand a little bit more and hopefully publish some results, and hopefully those results may contribute into the general scientific knowledge. So for the ovaries, we know that they need a little bit more time. The growth factors in the PRP injection, they need more time to work. I would, and there's beautiful ways to monitor it. One is by the under follicle count and the AMH. So I would probably wait 2 to 3 months before the egg collection, sometimes even more.
Right.
And sometimes if I see that the ovaries are moving, there is something happening there, I may repeat the injection after a couple of months.
Right. Okay. Thank you. And now we will go to
wonderful for ovarian PRP, if I can just add that.
Sure, of course.
Because we have I learn a lot from my patients. Sometimes I learn from my patients before I learn from the books and the journals and the conferences. A very good protocol that was suggested by all my patients many years ago. I didn't do it at the time, but now I remember that, and of course I have been incorporated that into my practice, is to do PRP on the day of the egg collection, but this is not going to work for this cycle, it's going to work for next cycle. We have quite a few of our patients with very poor ovarian reserve, very poor response to stimulation, even women just undergoing natural cycles. So I find it very useful when you do the aspiration for the 1 or 2 precious follicles or 3 precious follicles, when you finish the aspiration, to inject PRP into that follicle. I mean, firstly, the target is there, the needle is there, the procedure is under the same anesthetic. It's not, it doesn't take much longer to complete. And then, of course, that the effect of that may be evident next month or in a couple of months ahead.
Interesting as well. Thank you so much. And let's have a look at this question. So can someone who is not an IVF patient in your clinic do only hysteroscopy as a procedure? And on which day is the best to perform it?
Anna, I'm sorry about this question. Of course is the answer. But I'm sorry that, some of my colleagues, they're a little bit restrictive to other patients. Even if we contribute with a phone call and with good luck to any of our patients, to any of our viewers, that is very positive for us. So the answer is, of course, yes. Anything we can do to contribute a little bit in anyone's journey by any possible means is something, this is our ethos. So by all means, you're very welcome if you want to attend just for that, or if you want to get some second opinion on that, just drop a line and I would be delighted to offer it to you.
That sounds good. Thank you so much. And now we will go for our final question for today, I think. So let's have a look at this. So how do you reconcile hysterectomy in the background of bleeding in the ongoing miscarriage? If you can answer that as well.
I'm sorry, I don't understand the question. What do you mean?
Yeah, if you can just let us know exactly what you mean by that, we'll be happy to answer.
You mean probably hysteroscopy, not hysterectomy.
Not sure here. This is the question, and please just let us know what you mean exactly. So
do you mean hysteroscopy?
Possibly, but let me have a look. We can go back to this. We still have one more question, I believe, here. So let me just show you. In the meantime, we can wait for the answer. Okay. So do you do sub-endometrial PRP via hysteroscopy? Is it more beneficial for thin lining in comparison to normal PRP in field?
I mean, to be honest, in theory, yes, it is more beneficial, but I don't do it as first line. I would only do it for the third category of patients, very difficult patients, very, difficult adhesions. But again, not as first line because it is invasive. Yeah. So I wouldn't do it easily. I would do it as second line in very difficult patients in whom I have tried the injection of PRP fluid into the endometrium and it hasn't worked, or it hasn't worked significantly.
All right, someone is typing, so let's have a look. And as I've mentioned, we will be finishing. So if you have any more questions, as Dr. Tsakos already mentioned, you can get in touch with the team at Embryoclinic, Greece, and I'm sure they will be happy to answer. And yes, I can answer this question. Of course, this is recorded, so you will have a chance to re-watch it. It will be available on our YouTube channel tomorrow and also on our website. And I believe that will be our final question. Dr. Tsakos, thank you so much, as always, for joining us here. It's been a great session. There are lots of comments here for you, for sure. And as you can see, there are plenty of comments here. I can show you. Thank you very much for such an enlightening webinar. Couldn't agree more. Before we finish, as always, anything else you wish to add?
Just encouragement, just hope. Things are moving on. We're getting better every year. The world's knowledge is accumulating. We discuss with each other. We don't know everything, but we have solved a lot of our questions from the previous years, the previous decades. So hang in there. It's a difficult journey, but with faith, the belief to the impossible, and trust, everything is possible. So hang in there, and there are some wonderful people all over the world. I mean, I'm very fortunate to belong to this elite club of IVF specialists, fertility specialists, because what I see is that my colleagues, they have the passion, and we share this passion for our patients. And the vast majority of our patients, at the end of the day, they end up with a beautiful family. So hang in there, and thank you so much for listening.
Thank you so much indeed. I just wrote that if you have any other questions, anything you wish to ask, or you would like to get in touch with Dr. Tsakos, you can also email me, caroline@europeanfertilitysociety.com. I am able to forward any of this. And I think Dr. Tsakos is just writing his email address or the team's email address, and you can contact anyone directly. It's always good to do that. info@embryoclinic.eu. This is the email you can also use and get in touch with Dr. Tsakos and team at Embryoclinic directly. Thank you so much, everyone. We will be back with Dr. Tsakos for sure. There are some more events coming up, so stay tuned. And of course, we will be back on Tuesday, 7 p.m. More topics are coming up. So just sign up, and I'll be happy to see you here. And as always, thank you so much for joining us today. Have a lovely evening, Dr. Tsakos. Thank you so much, as always, as well.
Bye-bye. Take care. Bye-bye.
Bye.